Yes. So good evening, everyone. So I'm Dr. Srinath. So yes, today's topic is rheumatology. So we are going to start with rheumatology today. Okay. So we are going to address all our points one by one. We'll go through the points, right? So yes. Good evening, everybody. Yes. Right. So we'll always start with my favorite question to everybody that how many of us like medicine? Right, so medicine is some topic which most of the MBBS students prefer, right? Medicine is a very clinical subject. Medicine is a subject which all of us love, not just because it's very relatable and it's very clinical, but if you go through all the subjects that we do in the MBBS curriculum, medicine is the one that actually makes it all worth it, no? It also always like makes it worth it. It makes us worth that to become a doctor. Whether you eventually become a surgeon, whether you become a gynac, whether you become a radiologist, medicine is never going to go waste, right? So we always want to know how to go about medicine. That's our first step of the day. So let's go one by one. So for every student who goes through MBBS curriculum, medicine seems very, very vast. Now, why does medicine seem vast? We must know that. So every point has got a reason that why does medicine seem extremely vast to us? Okay. Yes. So medicine seems vast to us because presently in the medical college curriculum, we are taught medicine in a staggered approach. We are always having a staggered approach that what happens is in the first MBBS, when we enter into the medical college, we are taught the basic sciences. Basic sciences, we have got anatomy, we have got physiology and biochemistry, right? In the second MBBS, we are taught about paraclinical sciences. And finally, we are taught in the third MBBS about the clinical sciences. So what happens is that in the present system of learning medical knowledge, that we are always getting it in a staggered approach. So what we learn in first MBBS has to be taken into the second MBBS and then to the third MBBS. But that usually does not happen. So most of you will accept that as we give our university exams every year, our mind tends to delete the information, right? For example, when we come, okay, my name is Srinath, so we'll come that. So what happens is that whenever we learn first year, we learn anatomy, physiology, biochemistry. After giving the first MBBS exam, we tend to delete that information. But obvious, nothing wrong about it. It's a very human tendency. Please remember, knowledge will only remain. The mind will only retain that knowledge which is useful to us. What is not useful will be deleted. So, how do we go about that? So, medicine, we want to make it concise and compact. So even though, right, so even though it is a vast subject to most of us, today our job is to make it concise and compact. So integrated approach is the way to go. So we are all very familiar that in the recent years, integrated approach has received lot of attention. Even many universities across the country are also trying to go for integrated approach. Though it sounds very idealistic, trust me, it's not easy to do. It takes over a period of time to prepare the faculty to go for that time. Okay. So how does it help? Let us know that. How does it help? So just let me tell you, right, we'll increase the volume at the back team and we'll go on. Okay. So technical problems we'll sort as and how we get. So how does this help? Having this integrated approach, how does it help? That's what we want to know. So let us look at this. So medicine is a completely applied science. So medicine is completely an applied science. So you are not just, we'll go with this one by one. Yes. Okay. So initially few points we'll keep solving the technical things and go along. Right. So medicine is an applied science. So how does we actually reach medicine? How do you actually reach medicine? That's what we want to know. So let us welcome our first MBBS subjects. We want to welcome our first MBBS subjects where we are taught anatomy, we are taught physiology, and we are taught biochemistry. So anatomy is a structure, study of normal structure. Anatomy teaches us what is normal structure. Physiology teaches us normal function. And biochemistry teaches us normal metabolism. So when we enter the first MBBS, this is what we are taught. We are taught normal things about the human body. We are taught what is the normal structure, the normal function, and the normal metabolism that is occurring in the body. Now let's welcome the second MBBS subjects. In second MBBS, we are taught pathology, we are taught microbiology. Now what happens here? So what is this pathology actually? If you look at pathology, pathology is the study of abnormal structure. Abnormal structure, that is abnormal anatomy. It also includes the study of abnormal function, that is abnormal physiology, and abnormal metabolism. So basically, the pathology is nothing but a study of abnormal structure, abnormal function, and abnormal metabolism. That is what is pathology. Along with this abnormal qualities of the system, pathology also deals with the diagnostic test. Along with the study of microbiology, which teaches us about infectious agents. What we are doing, we are able to reach the diagnosis in the given patient. Once you diagnose the disease in a given patient, what we want to do next is to start the treatment. So after pathology, after the diagnosis comes the treatment of the disease. So treatment, as MBBS students, we are taught under the subject of pharmacology. So from diagnosis, we go on to the treatment. After treatment of the patient, the job is not done. We also want to know how to prevent the recurrence of the disease. So for recurrence of the disease, we are taught PSM. We are taught preventive and social medicine. So what happens is that it's a step-by-step progress. In first MBBS, we are taught what is normal. In second MBBS, we are taught what is abnormal and how to diagnose the abnormality, along with the knowledge of infectious agent in microbiology, along with the knowledge of treatment in pharmacology and prevention in the PSM. What we are learning is actually medicine. So medicine is it's a completely applied science. There is no de novo things in medicine. It is just an integration of the basic sciences with the paraclinical sciences and finally reaching our clinical science, that is medicine, right? So we have to go step by step. So don't worry. Here we are here to teach you from the start. I don't want to teach you anything that is direct. So what should we do? So to know this integrated approach, so most of us are aware, so some of you will accept that we are not taught much in our medical college, and most of us will also accept that we are not taught much in medical college. So we want to know that how to approach our subject today. So in our class, when we talk about rheumatology, we are not going to start with the disease of rheumatology. So I'm not going to start directly with disease of the rheumatology. Rather, I'm going to start with the basic. Okay, I'm going to start with basics of the system. So today we are going to learn about rheumatology, but we are going to start with the basics. That is first MBBS. Then we are going to learn symptomatology of the disease concern. Then we are going to learn the assessment method. So it is like a story. Okay, it is like a story that we want to know what is normal system. We want to know what are the symptoms in an abnormal person. If the patient comes with abnormal function or symptom, we want to know what are the tests that we want to do. So test we want to do, we want to know the assessment methods. After diagnosis, we want to classify the disease, and then only we want to start individual disorders. So it's a stepwise approach that we are going to learn in our class today, how to approach medicine. It's a stepwise thing. First the basics and symptomatology, then the assessment method, then the classification, and then study individual disorders. So how do we do this? Even among the individual disorders, we want to take one step forward. Because if you read any textbook of medicine, you will see that there are couple or more pages about the disease, same disorder. There are multiple pages on the same disorder. But we don't want to learn so much information. We want to learn what is relevant to us. So we need to organize the notes that we make. We want to make concise, compact notes, yet comprehensive. The notes must give answers to all the potential questions that can be asked in our exam. So how do we proceed like that? So organized learning, how do we proceed like that? So one, about every single disease, I want us to make a proforma. So first of all, I want you to be all oriented to the way of teaching, right? Every faculty that you meet is going to have a different way of teaching you. So since you are connected to me over the next 7 days for this topic, I want you to be synchronized with my style of teaching. So we are going to follow step by step. We are going to start with the basic, then we are going to come to the individual disease. And about each individual disease, what are we going to learn? Please write it down. We are going to start with the definition or the introduction to the disease. My professor always used to tell me that whenever you read about a particular disease, please emphasize to yourself that why are you reading that topic? Okay, all of you will agree with me. Why are we reading the topic should be made clear to us. So unless we know why we are reading the topic, we will not be able to take it forward. So we must know why to read the topic. That is part of our definition. Then we want to learn the epidemiology. So what is epidemiology? Epidemiology is basically the gender and the age preponderance. What is the age of onset and what is the gender preponderance comes under the heading of epidemiology of the disease. So it is very important part in medicine to know the epidemiology. Because when you have the same symptom in a different age group, different gender, the diagnosis also becomes different. Take a simple example. If you have a patient in your clinic complaining of cough, and if the patient is a young girl who is complaining of cough and rhinitis, you are going to suspect allergic rhinitis. But at the same time, if you are going to have an elderly male, a smoker who is complaining of the same symptom cough, your mind is going to start thinking of COPD as well as possibility of a lung cancer. So that's what is important about the epidemiology of the disease. Epidemiology is also important to us, right? Next comes the etiopathogenesis. When you talk of etiopathogenesis, we want to know what is the cause of the disease and what is the mechanism. Please learn to differentiate. Etiology means cause. Pathology means mechanism. They are different from each other. Many diseases which we don't know the cause, we end up using the term idiopathic. When we say idiopathic, that means we don't know the cause. Does not mean we don't know the pathology. We may know the pathology, mechanism of the disease can be identified, but cause can remain elusive. So we want to know etiopathogenesis. This is the basis of medicine. If you know the pathology, you will be able to understand the clinical features of the disease and also plan the test and treatment of the patient better. So focus is on etiopathogenesis of the disease. After knowing the pathology comes the clinical feature. Yes, we will start. Don't worry. We will not take time. What is important needs to be reinforced. So whatever you all tell, the pace is going to be set and all of us are going to reach the same destination with me, right? So we want to start with the clinical feature. Regular batch also, don't worry. We will make sure that you have enough information to add to your notes and also to learn more. Okay, so nothing wrong in going through this. So clinical features of the disease also include two set of symptoms. Please learn to look at them. One feature which is common but non-specific to the disease, and then there is those which are rare symptom but which are specific or pathognomic of the disease. So learn to differentiate and highlight those symptoms when you read about a particular disease. Once you have a clinical feature, you must learn to make a list of differential diagnosis. That is the main job of a physician. Then you work on the diagnosis in this patient. So diagnostic test also, there will be screening test which are sensitive. There will be the specific test which are confirmatory of the disease. Please remember, in MCQ, we are going to be asked what is investigation of choice or the gold standard test to identify the disease. Then we go on to the treatment. After diagnosis, see, medicine must be like a story. Okay, must be like a story. Every patient must be like a story in front of you. When you see the patient, the age, gender, symptom, you suspect the disease. You do the test, you diagnose the disease. You treat the patient. Treatment followed by explaining prognosis to the disease. So we want to know prognosis of the disease to end the completeness of the knowledge regarding that topic. So this is the system we are going to follow. We are going to follow here. So the notes, face-to-face class who have attended also, there are similar notes, same notes, most of them. Some additional points may be there, some basic concepts we have added so that we can understand whatever we have written better, right? So let's make use of this time that we are getting. Right. So let us go forward. So in my class, everybody who is just waiting, just remember, it is just a give and take relation that's going to be there in our class. The simple point is what? If you give attention, you get information. If you give involvement, then only you get knowledge. Please remember, only reading newspaper is just information. Only if you involve yourself, it becomes meaningful information, that is knowledge. Interaction. If you interact, if you discuss and ask me doubts, okay, and not irrelevant points, then we will learn better and you will grow in confidence. And finally, if you revise, that is when you get our PGC, right? So this is the simple steps we want to follow in our class today. So we want to follow these simple steps one by one. So all of you, please be clear, in our medicine class, I will be covering your rheumatology and eventually I'll be taking cardiology. So we want to be synchronous with the style of learning. We want to start with physiology, go on to symptomatology, understand the assessment, and then read the individual disorders, right? So let's get started. Right. So let's go for it. Let's get started. Right. So today's topic we are talking is rheumatology. See, trust me, all of you will feel that it is a repeat because you have heard it. But what we have heard till now forms the basis of our learning arc. Unless we know how to learn, we will not be able to learn the amount of information that we are needed to know. Please remember, again I am telling and reinforcing the point, it is not the people who work hard who get the seat. It is the people who work smart. It is not just the hours that you put. It's also the organized learning that you must have so that you can achieve your target. Right? So let us start with the topic rheumatology. Let us go one by one. Right? So what is rheumatology? So rheumatology basically is the study of systemic autoimmune disorders. So what is rheumatology? It is a study of systemic autoimmune disorders. Okay, so in MBBS, rheumatology is a underestimated, neglected topic in MBBS curriculum because for most MBBS students, rheumatology begins with SLE and ends with rheumatoid arthritis. Okay, so we have very limited knowledge of rheumatology, but we want to start with the basics. So rheumatology is the study of systemic autoimmune disease. So what is this? So we have got two questions in our mind. Okay, so let us prepare the questions in our mind and then answer them one by one. We want to know. Yes, I want you to write, okay, step by step. From here we can write and just follow it step by step. Smart work means whatever we just discussed. Gopal Bobde, काय असतं smart work? Just what we discussed is to plan your day. That is smart work. So we must know what are the questions we are attempting so that we can answer them better. So we know what are autoimmune disease, that is one question. And second question is that what are the causes and mechanism involved. What are the causes, mechanism involved in the development of autoimmune disease. So as I told you, this is rheumatology. This is rheumatology. Yes, you must write that. So this is rheumatology. But in our integrated approach today, right? So in our integrated approach today, what we are going to do? We are not going to start with the disease directly. We are rather going to start with the physiology of the immune system. That is our MBBS. We are going to start. Yes. So yes, you can write, add it to the notes. Okay. Add it to the notes. Few points which are extra, you can write them on sticky notes and add it to your notes. So review of physiology of the immune system comes first. After reviewing the immune system physiology, we are going to classify the disorders. And after classification, we are going to discuss antibody testing, that is assessment method. And then we are going to study the individual disorders. So this is our simple plan for the day. Okay, for entire topic of rheumatology, this is the plan for us. I'm going to give it very simple to you. First, we want to learn physiology of immune system. We want to do classification of disease, discuss the antibody testing, and study the individual topics, right? So let's go forward with this. So first step is to learn about the normal immune system. First step is to learn about the normal immune system. Okay. So don't worry, there is no division of India. Some people are commenting. So I am a total mixture of national integration. I am a Tamilian, born in Delhi, brought up in Bombay, married to a Maharashtrian. So I have got all four corners of the country with me, and I'm very proud to be a part of our country. So let's go on, right? So without wasting much time, I know people are restless. So we'll go ahead. So first is to review the normal immune system. Okay. I want you to follow. I want you to type the answers now. Okay. Your comments are very, very great. But let's come to the answers now, how we go about. So immune system is divided into the two. Broadly divided into A, the innate immunity, which is primitive right from the invertebrates, and adaptive immunity, which is modern, present only in the vertebrates. Okay, so let us start like this here. So immunity is broadly divided into the two. Yes, please let us start from here. So there is innate immunity and adaptive immunity, the two types of immune system. So I want you to make a table. I want you to make a division in your page. On one hand, we want to make the column for innate immunity components. On other side, we want to make a column for the adaptive immunity components. Let's study them one by one. Right. So we say that it is covered in microbiology. SK, I want you to answer what is covered in microbiology. I want you to tell the stories here. Right. I want us to know this topic from you. What are the components of the innate immunity? Okay, I want you to type out whatever you can, that what are the components of innate immunity. I want you to tell me. So it is right that it is an integration of what we learnt in pathology, in microbiology. Yes. So we want to know that what is the points here. What are the components of the innate immunity? I want you to focus, right? So components of the innate immunity. Number one. So just remember, innate immunity, it is like how the security system of the body. Immune system is nothing but a security system of the body. So how our community has got a defense system. Try to relate with that. So whenever a robber wants to enter into your house, yes, very good. I'm very happy. Keep going, but you are attempting few of them. Very good. So what we have got, that we have got here, that there is the robber tries to enter the house. What is preventing is the door to the house. If the robber manages to break the door, enter the house, we must have an alarm system. We must have the local security guard, and then local security guard will catch the robber, take him to the police. Police will present the robber to the judge, and then the statement will be given to the robber. So our immune system is also organized in the same manner. So number one, anatomical barrier. Anatomical barrier, yes, we can cover. Priya, don't worry, we'll cover everything. Rheumatology with all points will be done in 5 days. We'll try to take up whatever extra points we can. High yield topics we will cover. So first is anatomical barrier, that is example, the skin, mucous membrane, etc. So the moment we have got here, we have got the anatomical barrier. Number two, if the anatomical barrier is breached, we have got pattern recognizing receptors, which are like the sensors, alarm system of the body. And then we have got antimicrobial peptides, which try to neutralize the antigen. So in our body, in this case, what we want to know is that we have to know components of innate system. So there is anatomical barrier, pattern recognizing receptor, antimicrobial peptides, which are yet non-cellular components. Once the antigen is crossing the barriers, initial barrier, we are going to have the cellular components. Of the disease. Cellular components include the natural killer cell. Cellular components, please add this point. Cellular components include natural killer cells. So natural killer cells are one type of immune cell which have got non-MHC restricted action. Non-MHC restricted means they are the only cells which can also attack the self cells. So our body immune system recognizes the self versus foreign antigen based on the presence of MHC antigen. So MHC antigen, if it is present on the cell, the immune cell cannot attack the cell. But natural killer cell has a non-MHC restricted action, and hence even our own cells which become old, degenerated and cancerous, they are going to be removed by the NK cell. So even those cells which are our own, expressing our own MHC, but they are having the virus infection, or they have got precancerous stage, or they are degenerated, they can be removed by the natural killer cell because it has got a non-MHC restricted action. So hence both the immune and the tumor surveillance, it is useful in the NK cell. Okay. So the previous slide, just for a minute, the first component, we are going to review this. Okay, just listen to the class. Anatomical barrier, pattern recognizing receptor, antimicrobial peptide, and the cellular components we are enumerating now. Cellular components, we have got the NK cell, which is the first line of immune defense. After the NK cell, the monocyte macrophage system engulfs the antigen. Monocyte macrophage system engulfs the antigen. So this monocyte macrophage is like the policeman of our body. It is like the policeman of our body. Why? Like police are patrolling sensitive areas of the body, there are few macrophages which are guarding the special sensitive areas of the body. So if you look at it, yes, all these are innate components only, innate immunity components. So what I want you to remember, monocyte macrophage system are like the policemen. So why? Because organ specific macrophages are also there. When we look at it, the areas, common routes of infection. Look at the common routes of infection. Inhalation route. Inhalation goes to the lung. From food that we eat, it goes to the liver. Right? Brain is the important organ that we have. and the skin, direct entry of antigen or pathogen can occur in the body. So to guard us from these infections, these entry points have got the specific macrophages, organ specific macrophages. Yes. So Fernando, whether we have to write or not, it is our choice. No. So these are all points that we have to write. Yes, we have to write it in our own books one by one. We are enumerating the components. So as I told you, on one column we have made for the innate immunity. We are writing the components of innate immunity. We wrote the first three non-cellular components. Now we are writing the cellular components. One is the NK cell, second is the monocyte macrophage system. We all know Kupffer cells are present in the liver. Clara cells are present in the lungs. Clara cells are present in the lungs. Langerhans cells are present in the skin and microglial cells are present in the brain. So these are specific. Clara cells are present in the lungs. So macrophage, what it does, like the police arrest the robber, macrophage is going to engulf the antigen. But after arresting the robber, the police have to present the thief, robber to the judge. Who does the job in our body? After the antigen or pathogen is engulfed by the macrophage, it is the dendritic cells. Dendritic cell, which are the most potent APC, antigen presenting cells. So they present the antigen which is inside the macrophage to higher levels of immunity to study the epitopes and prepare mount a better immune response. So the job of the dendritic cell is called as antigen presentation. Dendritic cell is called antigen presentation. Very good. Then we have got the granulocyte series. So sometimes when the police are unable to control the crowd, there is a sudden riot, then you require a rapid action force. Similar to rapid action force in our body, we have got the granulocyte series. Granulocytes are the ones which are neutrophil, eosinophils and the basophils. They come when there is an acute problem and then they will go away. So these four are the cellular components of the innate immunity. So cellular components of the innate immunity, we want to look at them. So we have got four cellular components in the immunity. Very good. If you learnt it in immunology, I am very happy. Just continue and revise with me quickly. Because unless we remember these points, we may not be able to understand medicine better. So no harm done. Right? So we are going slow. It is not possible for me to write much. So that's why I have made slides in a very sequential manner, one line at a time. So you can write with me and there will be no hurry. There is enough time for you to understand and copy down. I am not expecting you to become a typewriter. I want you to become a doctor. So please focus that I want you to listen, understand and write. Don't hurry anywhere. Nobody is going and these videos are going to be uploaded. So it's not that you are going to miss something. I want us to just look at the point, right? So we go to the complement system. So complement system cascade does the job of opsonization. That is, it marks the target. It's very important. Complement cascade does the job of opsonization and it marks the target. So sometimes when the robber is hiding inside somebody's house, the police cannot identify the robber. So who helps? Informer. So complement system is like an informer of the body. The complement binds to the antigen and calls the other inflammatory cell, immune cell, to the site of infection. So it is like an informer which attracts the other immune cell to the site of infection or inflammation. So that's what we want to look at that. And please remember, in clinical practice, please remember, whenever complement system is activated, what you will get in the laboratory testing, you will get low C3, C4 levels in the serum. Please remember, when complement is active, serum level will not increase. Serum level will decrease. Complement level will decrease. And that is what you will get. Right? That is complement cascade for you. Coming further, So cytokine system. So we have got this cytokine system, which is the control room, Cytokine regulates the immune response. It is both pro-inflammatory as well as anti-inflammatory cytokines are present, and it is the regulator of the immune response. So every single component of the immune system has a specific role to play in the system. So how we want to catch a robber, you want to catch a terrorist, it has to be a synchronized, organized effort. And that's what our immune system is also going to do, right? So this is the cytokine system which regulates the immune response. Among the pro-inflammatory cytokine, the most potent, please write it down, most potent mediator of inflammation is the TNF alpha. All of you will be asked, in the practical viva that when a person with infection, why does he experience a fever? Why does they feel myalgia? Constitutional symptom. Have you heard of constitutional symptoms? Myalgia, arthralgia, anorexia, weight loss, which you see commonly in a tuberculosis patient. All this is going to be done because of the tumor necrosis factor alpha. So TNF alpha is responsible for causing these constitutional symptoms, right? So what we want to do is to go through the proper system. Okay, so let us look at it again. Okay, we'll come back to this. Let us look at this properly, that what are the components. I'm going to summarize components of the innate immunity. Summary, let us see. So innate immunity is like the low level security, policeman, security guard. These are all our immune system. So let us look at this, right? So what we have got here? So we have got anatomical barrier, pattern recognizing receptor, antimicrobial peptides. So first three components we have got anatomical barrier, pattern recognizing receptors, antimicrobial peptides. And fine, then we have got the four cellular components. NK cell, monocyte macrophage system, dendritic cells, and the granulocyte series, which help in the immune response. And we have complement cascade and the cytokine system. And we have got the cytokine system, right? So what we want to do? We want to look at these points here. So anatomical barrier is like the door. Pattern recognizing, these are like the alarm system of the body. NK cell are like the local security guard. Monocyte macrophage are like the policemen of the body. Dendritic cells are those policemen who present the robber to the judge. Rapid action force is the granulocyte series. Complement series are the informer, and cytokine system is the control room of the immune response. So our immunity works in a very well coordinated manner to ward off the infection, and that is how it helps protect our body from the various threats that we face every day. But sometime what can happen? Sometime the innate immunity can be overpowered. The antigen or the pathogen is more potent than who we have to call. Suppose instead of robber, it is not a regular robber, it is a terrorist. Then we may have to call the army also. So who is our army? We have got adaptive immunity. Adaptive immunity is the more sophisticated, more advanced, more potent level of immune system. It is like calling the army. So when we look at it, okay, what we have? Adaptive immunity, easy to remember. Innate system had 9 components. Adaptive has only 2 components. All of you are knowing. We have got B cell mediated, that is humoral immunity, and we have got T cell mediated, that is the cell mediated immunity. That's what we got, right? So simple points that we have it here, right? So we will go step by step. All your questions and doubts I'm reading, and I will solve them one by one. Wherever you are getting stuck, I'm reading them. We will make a summary and put out all these doubts. Okay, we'll get all your answers, don't worry. because as much as you want to learn, I'm more obsessed about teaching. So don't worry, nothing will be left. You will be all satisfied and then only go. So let's look at this. Adaptive immunity, there is only two. There is B cell and there is T cell mediated immunity. So look at more details of the B cell. Look at it into the more details of B cell. So B cells do not directly produce antibody. Please focus on line number 1. B cells do not directly produce antibody. The B cells need the presence of BAF or BLYSS for their activation. So what is this BAF and this BLYS? We have B cell activation factor and the B lymphocyte stimulator. So unless BAF or BLYS is present, we are not going to get activation of B cell. Only when they are activated, they coalesce to form the plasma cell. And the plasma cells are the one which secrete the antibodies, which are our immunoglobulins. So that's how it is. So it's going to come one by one. So B cells express, we want to learn to identify the cells. What is the unique marker? CD marker, cluster differentiation marker. We have CD19, CD20 on the cell surface. So when we look at B cell, humoral immunity, they express CD19, CD20. We must know this physiology because all this is needed to correlate with the treatment options in medicine. So we have to always revise the basics. Even if it is time consuming, trust me, integrated approach might seem time consuming at the start. But once you know the basics, I keep repeating it. Listen, each one of you who is making noise, listen to me. If you know the basic sciences, trust me, you will not have to read Harrison. You can write Harrison. Okay. So trust me, medicine is a derived subject. There is nothing out of fluke. So focus on basics time and again. So T cell, going on to the next cell type, there is T cell mediated immunity or the cell mediated immunity that we have. So T cells are the most potent level of the immunity. T cells are the most potent cells of the immune system and they are going to express the CD4 and the CD8 depending upon whether they are helper or cytokine T cell. Right? So just we have to focus. There is nothing great about medicine. Medicine is about knowing your basics well and learning the art to apply them with your clinical cases. Once you can get this integration done, it's going to be extremely easy for all of us to go through. So we have got a brief summary here. We have got the knowledge now of the basic immune system. Take time. It's okay. It is worth it. So we have got here that we have got the innate immunity, adaptive immunity. Innate immunity is the primitive form, 9 components. Adaptive immunity is the more modern form which has got 2 components and together they protect our body from all the invasions of antigen and pathogen. So now let's come to classify the disease. Okay. So I have written Abhishek for you BLYS, what it is, B lymphocyte stimulator. Here right below BLYS is what? B lymphocyte stimulator. It is the B lymphocyte stimulator. Right? So let us go through this point again. So this is what it is. There is simple 2 levels of immune system that we have reviewed. This is the review here. This is to understand what is clinically relevant to us. Okay, what we learn, everything in the basic science may not be relevant. Something is for understanding. But now with the next level, and the next level of learning is what? Learning to take the clinical matter out of the basic sciences. That's what we want to learn. So coming to step number 2. Okay, so if you all remember, first we wanted to review the immune system. Now we want to classify the disorders. Okay, everybody focus on this. So we want to look, immune system disorders can be broadly classified into the 2 types. Okay, everybody, the immune system disorders can be classified into the 2 types. So immune system, pathology is an extension of physiology. Again, I'm telling, pathology is extension of physiology. So if physiology has 2 types of immunity, pathology also will have 2 types of problem. So immune system disorder can be A, immunodeficiency disorder, or it can be B, immune excess states. Very simple. So immune system is normal, protecting my body. What can be the disease? Either a deficiency or over responsiveness of the immune system. These are the 2 points that we have to know about this, right? So what is the point here? Immunodeficiency disorders. So this immunodeficiency part, I want you to first understand. I want you to integrate with your pathology class. Immunodeficiency disorders you are going to cover in your pathology class. So which are they? Here we are going to enumerate them today so that you get a complete feeling of the topic that we are discussing today. Okay. So there is a query that we are first explain, then make us write. So Calvin Williams, I am not the one making you write. I am explaining only. You can listen to that and then write. Writing is not my part and I am going very slow. See, over 7 years of teaching, I have realized that majority students feel that I go slower than normal only. It is never occurred to me, anybody has told me that sir, you are going too fast. Okay, I am a very slow fellow only. Okay, so slow teacher. So let's go through that. Okay, so let's go through that one by one. So immunodeficiency disorder. So immune system, we have classified it into 2 types, the immunodeficiency and the immune excess disorder. Okay, all these slides are going to be there in your video, no? So you can go through that. Yes, they are the same. BAF and BLYS are the same. Okay, so they are just different terminology for the same thing, right? Okay, so immunodeficiency disorders, we will divide them. One, innate immunity disorders, adaptive immunity disorders. Very simple. Let's go through step by step. So we have got innate immunity and adaptive deficiency disorder. All of you will know this, that innate immunity, severe congenital neutropenia. Okay, innate immunity examples that you will discuss in pathology are severe congenital neutropenia. You will discuss about asplenia. You will discuss about complement deficiency, Mendelian susceptibility to mycobacterial disease, and chronic granulomatous disease. So simple points. Okay, simple points. We'll take it one by one. So we have got innate immunity, immunodeficiency disorders. Just for enumeration purpose, you are covering this with pathology. Adaptive deficiency disorders are probably more famous with you. All of you know SCID, severe combined immunodeficiency. All of you have heard of Digeorge syndrome, thymic aplasia, hypoplasia, Wiskott-Aldrich syndrome, variable immunodeficiency, and IgA deficiency. So what I have done, I have first given you overview of the topic we are going to study. It's most important that we get these basics right and build our knowledge on these concepts. So immunodeficiency, you are going to listen, we are going to understand in pathology details of these disorders. But just wanted to emphasize how pathology is extension of physiology. There are 2 components of immunity, there are 2 disorder types also. So let's going up forward. So immune excess disorder. So immunodeficiency went to pathology. So we are still here to answer the question, then what is with rheumatology? All of you have gathered today to learn rheumatology and we defined it. It is the study of autoimmune disease. Okay, everybody, we have written that rheumatology is a study of systemic autoimmune disease. So it is an immune excess disorder where immune system is our enemy rather than being our friend. But as the physiology says, immune excess also can be 2. It can be excess of innate immunity or excess of adaptive immunity. So excess can be of innate immunity also. It can be excess of adaptive immunity also. Which one of them is autoimmune disease? Okay, I'm going to wait for all of you, right? So which is the autoimmune disease? Which is autoimmune disease? Is it excess of adaptive immunity or excess of innate immunity? Okay, which is excess? Okay, slow down. Let us take notes. Okay. We'll all take notes here. And as you take down the notes, okay, the answer to the question also, very good. So adaptive immunity. So autoimmune disease, okay, for people who have missed, you can write down the notes. Others will continue as the discussion, at least we will take it forward. Very good. So adaptive immunity excess is called as autoimmune disease. So there is excess of T cell or excess of B cell. That is why patients with autoimmune disease have got autoantibodies because of excess B cell activity. Okay, so adaptive system is the immune excess autoimmune disease, right? So what are the components? So again, coming to the question here, that what is rheumatology? Is rheumatology the study of autoimmune disease? So again, we are at that juncture, we are asking, is it the study of the autoimmune disease? So answer is no. Adaptive immunity, they are the autoimmune disorders. But autoimmune disorders can be further divided into two types. Majority of the disorders, autoimmune disorders, can be organ specific. Autoimmune can be organ specific. For example, myasthenia gravis is there, Graves disease is there. So all of us know myasthenia is covered in CNS class, Graves disease is covered in endocrine class. So even though we have got autoimmune disorders, many of them, we are not here to discuss all of them. Majority of them are organ specific, which will be dealt with the dominant system involved. So what are we here to study? What is rheumatology? That's the question here. What is rheumatology is the question. So some of the disease have multi-organ involvement, that is systemic manifestation. Now most specialists are saying there is no problem, हम लोग कैसे treat करें? How can we treat this patient? Multi-system. So multi-system diseases did not have their own branch, and that is what constituted the branch of rheumatology. So today we have understood here that rheumatology is the study of systemic autoimmune disease. So please remember, for the entire duration of rheumatology class, the pathology of all diseases is the same. Please remember, pathology of all the diseases is the same. They are all autoimmune in nature, and all of them will have multi-system involvement, and that is why they are included under the topic of rheumatology. So before we come to rheumatology, we must also know what are innate excess called. What are innate excess called? Innate excess are called auto-inflammatory disorders. Please note down, innate excess are called auto-inflammatory disorders. Okay, so we have got the innate immunity excess are called auto-inflammatory disorders. Okay, so auto-inflammatory disorders, we may have not read them, but actually we have studied the topics under them for our university exam and MCQ. You will remember when you read the detail. So auto-inflammatory disorders, majority of them present with recurrent febrile episodes. Majority of them present with recurrent febrile episodes, and hence they are included under the group known as periodic fever syndromes. So they are nothing but the periodic fever syndromes which are under the heading auto-inflammatory disease. And the two famous topics that we want to cover under them are the topics familial Mediterranean fever and the familial Hibernian fever. So these are the two we want to see. Right. So we are looking at familial Mediterranean fever and the familial Hibernian fever. Okay. So rheumatology is a very important topic. It is a very small topic but has got high yield in the MCQ. This year in the NEET and AIMS exam, we have got more than 7 questions from rheumatology in both exams together. It is a very small topic. In my class who have attended, no, entire rheumatology can be written in just 25 pages. And that 25 pages will give you 7 to 8 questions. It is a high yield topic, right? So we want to focus on learning these two topics. So immune excess is adaptive. Right. Okay, so what are these topics here? So we proceed further, that rheumatology, right? So rheumatology, this is our basis that we have built today. So we know the physiology of immune system, we know the classification of the disease, and that's how we have learned this point. Okay, so this is where we are. We know what is autoimmune disease, we know what is rheumatology, and we also know what is our auto-inflammatory disorder, right? So coming ahead, so what are we doing? Recall to what we have done here. So this is the definition slide we have written. Rheumatology is the study of systemic autoimmune disease. So first question we had asked, what is autoimmune disorder? So all of you, I hope we are clear. Autoimmune disorders are adaptive excess state. Autoimmune disorders are adaptive excess state. And we have written what are the causes or mechanism involved. So we have written what are the causes or mechanism involved. We have got it here. We have understood first part of the question in rheumatology. What is it? Now we want to know what are the causes or mechanisms involved. But before we go to this causes and mechanism involved, if you look at this table that we have made, I will be able in the live class most of the time I am going to hear the question that this one is left now. Arey, auto-inflammatory disorder ka kya? So before we enter the rheumatology, that is the autoimmune side, we want to first complete the topics under the auto-inflammatory disorder. So before we go into rheumatology classification, let's complete FMF and TRAPS. So let us take them one by one. The periodic fever syndromes, two of them are important for us to review today. Two of them are very commonly asked in MCQ, though these two syndromes important in this group need to be revised. So which are they? So number one, we have got the familial Mediterranean fever, and number two, we have got the familial Hibernian fever. These are the two topics that we want to study. One, familial Mediterranean fever. Number two, familial Hibernian fever. But please remember, name change. Anna, we must all know. So what is the point here is that all of us students, we have read so many different names of the disease and always wondered कि इतना नाम बदलते क्यों है? Why not stick to one name and be happy with that? So what used to happen in old times? Old times people used to love naming the disease after the scientist who first described the disease, or based on the geography where it was first discovered, based on the geography where it was majority population have the disease. But now in the modern world, with worldwide migration and worldwide net, who discovers always remains an enigma, and disease can occur anywhere. So all the names which have got mentioned to Mediterranean, Hibernian name is because it was described in the Irish population. Hibernian name because described in the Irish population. These are no longer recommended. So any name which are still mentioning the geography are no longer recommended, because it is not right to believe that they occur only in those geographical areas. They are present everywhere, right? So where are they? We have got the new name, familial Mediterranean fever occurs in is the recurrent polyserositis syndrome, and familial Hibernian fever, that is TRAPS. TRAPS is the TNF alpha receptor associated periodic syndrome. So we have got the two important syndromes that we want to discuss today. Okay, so we have not started rheumatology classification, but we have reached what is rheumatology. So we are discussing first, before we enter rheumatology, we are completing the two syndromes from auto-inflammatory disorder, right? So one is FMF, other is the TRAPS, TNF alpha receptor associated periodic syndrome, right? So let's go on. Recall this for me, what we decided today, how we are going to read. We are going to start with the definition, the epidemiology, etiopathogenesis, clinical feature, diagnosis, treatment and prognosis. So about each individual disease, we are going to know about the salient points about each of the disease. That's what we want to start, right? So let us see here. So starting with our first disease, that is FMF. So when we start medicine, you will understand the value of knowing your basics. Now that you know your basics, you will find it much more easier to understand, remember the features and treatment of the disease, right? So starting with the most famous periodic fever syndrome, that is FMF, recurrent polycirrhosis syndrome. So one, we have got definition with the etiopathogenesis. It is an autosomal recessive autoinflammatory disorder. So first, always start with definition. We have got autosomal recessive autoinflammatory disorder. That is our FMF for you. What is this thing? What is it due to? It is the mutation in the MEFV gene. Okay, so I'm going with you one line at a time. Okay, TRAP full form, we have written it, told it thrice, tumor necrosis factor alpha receptor associated points. Okay, so what are the points here? FMF. Okay, same notes. See, because of the technical limitations, writing becomes very slow. Okay, that's why I'm not able to do that. So whatever I would have anyway written, I have made the slides so that one line at a time. So they are not going to hurry you up, and I will go slow accordingly so that you can complete the notes. So don't worry, we will go one by one line by one line we will do. We are not writing essay type question. We are writing whatever is relevant, and that much we will remember. So whatever is absolute essential, right? So FMF, autosomal recessive autoinflammatory disorder. All of you already know what is autoinflammatory disorder now. Number 2 point, what is it due to? Mutation in the MEFE gene. That is also easy to remember. MEFE means Mediterranean fever gene, which is associated with the production of pyrin. So pyrogen, the thing that causes fever, pyrin is causing overexpression of the inflammasome proteins, right? So pyrin causes overexpression of the inflammasome proteins, right? So inflammasome proteins are nothing but the PRRs. They are nothing but the pattern recognizing receptors, right? So pyrin is causing overexpression of the inflammasome proteins, which are nothing but the pattern recognizing receptors. So whatever points about each disease that we are trying to summarize here. So first step is definition with the etiopathogenesis of the disease. What is next is the epidemiology. So since it is an inherited disease, please remember, when it is an inherited disease, it is likely to affect young age people. So most commonly it affects the young males in the first to second decade of life. So being a inherited, when you say it is an inherited disease, means present since birth, it is likely that you are going to see the effect in the young patient. So 10 to 20 years of age, commonly affecting a male person, a boy, young boy, is affected in the disease FMF, familial Mediterranean fever, right? So what is this clinical feature? So what I told you, we want to know definition, etiopathogenesis, we want to know epidemiology, then we want to know clinical feature, how do they present? There is no specific reason why male. It is autosomal recessive, but statistically more common in the males, right? So there is no particular reason. So what we have is the clinical features. Yes. So clinical features we have got, it presents with recurrent febrile episodes. So again we have written autoinflammatory diseases. Already we have written that they are classified under the periodic fever syndromes. They are classified under periodic fever syndromes. So each episode lasting for 3 to 7 days. So because of the nature, see, pathology is same, no? All our autoinflammatory disease will have this common finding because pathology is the same. So they come with recurrent febrile episodes, which each episode lasting for 3 to 7 days. So along with that, constitutional symptoms will occur, but constitutional symptoms are non-specific. Even infections can have constitutional symptoms, and that does not make it abnormal. So what happens here? Serositis. As the name says, look at the name FMF. The new name always describes the pathology. FMF was the old name. The new name, polyserositis, describes the pathology. It describes the pathology, right? So 1 to 3 days is the minimum duration, and it can average last for up to 7 days. Okay. So there is an ambiguity in different sources. So maximum duration 7 days. So 1 to 3 days it can be minimum, or it can be up to 7 days. That is the duration of each febrile episode. But it is the serositis which is specific to the disease. That's why the name, the specific is, there is polyserositis. It is specific to the disease. And most common, the serous cavity involved is the pleural cavity. We have different serous cavity. We have got the pleural cavity, peritoneal cavity, synovial cavity, pericardial cavity. Most common is the pleural cavity. So most commonly, along with the recurrent episodes of fever, the patient is going to have pleuritis. Patient can also present with recurrent attacks of peritonitis or synovitis, or can come with pericarditis, which is the least common serous cavity involved. So in the order of commonness, pleural cavity, most common site inflamed, followed by peritoneal cavity, synovial cavity, least common is the pericardial cavity, which can be part of the disease. Along with that, we can also get scrotal swelling and rash over the ankle are rare manifestations of the disease. So what we are seeing, that scrotal swelling and rash over ankle, rare manifestations of the disease. So simple way, okay? So don't worry. Right now, all of you listen to me. This is the first class we are having. This is the first disease we are discussing. Once you get tuned, accustomed to the pattern of writing, you will find it easier to note down your notes. So first session, I will be slow, okay, but you will catch up. And as we make it a habit to read in the same format, you will be able to understand also and take down your notes also better. Okay, so don't worry at all. Okay, so first, again, I'm suggesting, first listen to me. If you are unable to write and listen at the same time, my first request is listen to me. After listening to me, you see what I'm pointing to, and then you can write it down. Because even if you miss a word or two, if you have heard it, you can write it. And again, I'm telling, the videos are uploaded on the app, so you will be able to go through them and catch up on those words. When you are only writing without listening, that means the information is not even reaching your cortex. Okay, that information is anyway useless. So might as well delete it. What we want to know is to go the slow, listen and write. Okay, there is nothing to worry. We will go through slow. Okay, so these are the clinical features of the disease. These are the clinical features of the disease. So most of the times it is a young boy who is going to come with recurrent fever episodes, having constitutional symptoms and also complaining of pruritus. And that's why I highlighted the point. In our country, if you have a young patient with fever, anorexia, weight loss and pruritus, the first differential diagnosis will be tuberculosis. So FMF can very much look like tuberculosis in our country. So we must keep it as a differential diagnosis. FMF can be a differential to tuberculosis because the most common serous cavity affected is serositis, right? Serositis is not a constitutional symptom. Constitutional symptom, I have told you. Constitutional symptom is what? Basically, constitutional symptom means non-specific symptom, where you get fever, you get myalgia, you get body pain, no? Like what we call a prodrome. That is more like a constitutional symptom, right? Not orchitis, just the scrotal sac and the skin around the ankle can be inflamed. These are rare manifestations of the disease, right? So that's what. So the slide has got all the information that I'm talking, but important is to visualize in a clinical proforma. That's what is important to us. Visualize in a clinical proforma. How does pleuritis present? It presents as chest pain and cough. Pleural inflammation, chest pain, cough will be present in this patient. So how do we diagnose? As I told you, we must have high index of suspicion. Because when we have a patient who is having fever with pleuritis or peritonitis, in our country, the first suspicion is infection. First suspicion is infection. So after we exclude infection, we must think of the other immune excess disease. And for that, genetic testing is confirmatory. So once you suspect the disease, then only you are going to ask for our test. Otherwise, in every young boy who comes with fever and pleuritis, you are going to first investigate them for tuberculosis. When TB is not there, when common infections are not there, I want you to suspect the rare disease. That is then ask for genetic testing of the disease. So genetic testing for the MEFV gene, pyrin gene defect, that is MEFV gene defect testing is available in the commercial laboratory and that can confirm the disease. So how do you treat and why is it important? So that comes to the point. It is important. It is important to diagnose the disease because the treatment of choice is colchicine. Now colchicine is a drug which we don't routinely prescribe. So unless we diagnose the disease, we are going to end up giving the patient anti-inflammatory agent and maybe steroid. Anti-inflammatory agent and steroids only relieve the symptoms. They do not stop the disease. They only relieve the symptom. They do not stop the disease. And that is why after making the specific diagnosis, it is important for us to start colchicine. Colchicine, why it is the drug of choice? Because not only does it relieve the symptoms of the disease, it also induces long-term remission. So it is important not only because it relieves symptom. If you give NSAID, that will also do that. But along with that, it also suppresses the overexpression of the inflammasome protein. It's a chain reaction. So inflammasome protein activation is also controlled when you give the patient colchicine. And that is why it is the drug of choice. So correct diagnosis will happen only when you have correct suspicion. And only when you make the diagnosis will you give the correct drug. And if you give the correct drug, then you will have good prognosis. But if you don't give the correct drug, the dreaded complication can occur. What is the dreaded complication? Untreated cases can succumb to renal failure due to secondary amyloidosis before 40 years of age. Right? So colchicine is usually given for minimum duration 6 months to 2 years. By that time, most patients go into remission. and only when the symptoms occur, we will restart the course. But many patients may require it lifelong because the disease cannot be cured. Disease cannot be cured. You want to continue it lifelong. Dose of colchicine is not important for you. Focus on what is taught, not on irrelevant points. Right? So what dreaded complication can occur? We do not want to start steroids. Steroids only mask the symptom. Okay, do not start steroid. And first you can give anti-inflammatory. Just to control the symptom, you can give NSAID. Wait for the genetic testing, then start on colchicine because there is no hurry. Because what is the complication? Read it with me. Secondary amyloidosis. What is amyloidosis? Amyloidosis is the collection, accumulation of the insoluble protein. Amyloid means insoluble protein. Accumulation of this insoluble protein is amyloidosis. So when there is a chronic inflammatory state in the body, acute phase reactant proteins are secreted and they accumulate in the body, and that's why we call it as AA type of amyloidosis. We call it as AA type of amyloidosis. Listen to the explanation. How amyloidosis? Amyloidosis means accumulation of insoluble protein. Because of the recurrent inflammation in the body, there is secretion of acute phase reactant proteins. These proteins are insoluble and usually have to be excreted by the kidney. But because of the recurrent inflammation, these proteins accumulate in the body. Because they accumulate in the body, it is called as amyloidosis. And with the which type? AA, capital A, capital A. Because first capital A stands for amyloid, second capital A for the acute phase reactant. Proteins accumulate in the body, leading to the problem. Because these proteins are normally secreted by the kidney faces additional burden, and that is what leads to renal failure, which becomes the cause of death. So amyloidosis is the complication which causes renal failure, which in turn causes death of the patient before 40 years of age if you have left it untreated. That is what is important to know. So in familial Mediterranean fever, it is typically young boy who presents with recurrent fever, non-specific symptom, pleuritis, peritonitis and other features. After excluding common infection, especially tuberculosis, you will ask for genetic testing. After confirming, you will start with colchicine. And if you start the colchicine, prognosis is good. If you do not start colchicine, you only give NSAID from time to time, you are going to end up with renal failure. Yes. Other drugs, if colchicine does not work, then yes, you can go for interleukin-1 antagonist, but that we will discuss in refractory cases. Right? So look at this picture. We'll understand it very simple. Right? Familial Mediterranean fever. All the multiple factors can come. So main problem, they present with episodic fever. Yes, they present with episodic fever. There is associated pleuritis. Most common pleural cavity is affected. Pleuritis. Peritonitis, who come with the abdominal pain, and there can be skin rash. Okay. AA stands for, A capital stands for amyloid. Another A stands for acute phase reactant. You have heard of primary amyloidosis. In primary, it is AL. A stands for amyloid, L stands for light chain. In hemodialysis, it is called A beta 2 microglobulin. A for amyloid. First A is always amyloid. That's what it is. Right? So that is how we want to continue here. So we have got episodic fever, main presentation, along with pleuritis, peritonitis, and you can get rash. These are the typical features of familial Mediterranean fever. So FMF rash can mimic gout, as we have written. Rash over the ankle. Ankle, when it is there, you can get the type, it can look like gout. Yes. all the serositis can occur in the same time. Yes, it can occur, but it is commonly, it can be multi-organ. That's why we call it any organ may be inflamed in the disease, right? So this is our summary of FMF. Coming to the second one. The second one, autoinflammatory disease, is the familial Hibernian fever or TRAPS. So second one is the familial Hibernian fever or the TRAPS. Okay. So each topic na, it's going to come multiple times. So worry mat kari. Don't get stressed ki one line miss hua, two line miss hua. No, it's going to keep coming. Again and again, there will be some recall slides so that I can make you understand better. Okay. So let us go slow. It is the second topic now, familial Hibernian fever or TRAPS. Okay, familial Hibernian fever. Hibernian because it is written in the Irish population. Now it can be seen worldwide. So how is it different? Focus on that. Though like it is FMF in the same group of disease, periodic fever, but it is much more rare and autosomal dominant disease affecting the TNF alpha receptor. That's why the name. As I told you, new names describe the pathology. New names can look like the pathology here. So rare autosomal dominant disease affecting the TNF alpha receptor. Epidemiology, unlike FMF, it can be seen in both genders. Epidemiology, it can occur in both genders and usually in the first decade. So FMF, like the FMF, we can expect early because they are inherited disease. Okay, inherited disease. Okay, Aisha is asking lack of pyrin or excess of pyrin. Excess of pyrin. Okay, there is excess of pyrin. MEFE causes the pyrin production dysregulation. So pyrin is the one which activates the inflammasome proteins. So it causes overexpression of the PRRs, which leads to the recurrent fever. Okay, excess is there. There is excess of pyrin in the body. Okay, coming back here to TRAPS. So this is our TRAPS. Let's continue further. Yeah, so tumor necrosis factor alpha related periodic syndrome. So what are the clinical features of the disease? Clinical features of the disease, again, because the pathology is common, again focus, understand group dynamics. Group features are similar. Recurrent episodes of fever are there, but here they typically last for more than 1 month. Typically they last for more than 1 month. 1 week, sorry, typically last for more than 1 week, which is different from the FM. It is also associated with the severe myalgia and rash over the trunk. So just to highlight the differentiating features. See, most of these rare syndromes, you are likely to see them in the MCQ paper than in clinical practice. So I want you to highlight that what is the differences between the two syndromes that we must look at. So we are got associated, there is severe myalgia and rash over the trunk and the arms. Over the severe myalgia and rash over the arms. So patient can develop here also serous cavity inflammation, and that is why it can mimic FMF. It can also develop pleuritis, pericarditis, and hence it can mimic FMF. Okay, so because of the similarity in the pathology, clinical features can also be similar or they can look alike. But how to differentiate, how to suspect clinically? Number 1 point, red swollen eyes. Ocular involvement is common. Please recall, in FMF there is no ocular involvement. In FMF there is no ocular involvement. Here in TRAPS there is a ocular involvement. There is a ocular involvement. Okay, right. Okay, so we'll go through that. Okay, I am also learning. If we'll try to make it that where I am putting the marker, we can also learn what is our focusing topic. Okay, I'll make it one by one. Okay, So Shakshata wants to know whether gout is of MTP. How does it mimic FMF? It is not like that. Gout can also affect the ankle, no? So it is just a point to say. It is a point to note that it can be a potential differential. Please remember, all I'm saying now, all I'm saying that as a student, I was also very inquisitive and I used to torture my professors that, sir, but you told like this, textbook it is written like this, like that. And the professor gave me one golden line, and that line is what, that medical students, doctors read textbooks. Diseases don't read textbooks. Okay, so what we read in textbook is just a classical point of the disease. Does not mean atypical forms cannot be there. So what we read na, at MBBS level, please try to concentrate. I am giving you information that is relevant to you. I am giving you information relevant to you, not the ones which are not important. So what we want to know, let us learn here. Okay. So other than FMF, we are going to have ocular involvement. Ocular involvement is present. Here also the diagnosis is by genetic testing. Diagnosis is by genetic testing. We are going to diagnose it. Ocular is also there, and then you can go for genetic testing to diagnose the disease. But here the difference is what? The difference is patient responds to steroids rather than the colchicine. So it is again important to understand because it's different. Here it is different that patient responds to steroids rather than the colchicine. So here the first line treatment would be to look for steroids. And untreated patients here also will develop secondary amyloidosis leading to renal failure as the most common cause of death. So here also we are going to get secondary amyloidosis leading to renal failure as the most common cause of death. So again understand, when we are having a disease, it is a group. So what we do as medical student is we try to read individual topics because they are asked in the university, we read the topics. But we don't understand the group they belong to. We don't focus on that, and that's why we end up duplicating information. But today, when we went to the enterograde, we understood first what is normal, we understood what is inflammasome protein, and then we know if there is a problem in innate immunity, you will get inflammation. And all of us know that if there is inflammation, we are going to get fever. So presentation of all the diseases under this group will be same, that is periodic fever syndrome. Now within the group, we have to understand how they are different between the two so that you can answer the MCQ better. That's all. That's how we want to focus here. So here what is the thing? The typical images. I want you to summarize how it is different in the traps. So traps, because it is like a auto-inflammatory, it becomes a differential of FMF because here also the child patient can come with the serositis. Patient can come with serositis. So serositis here, what is different is number one, the duration. In FMF, duration was up to 7 days. In traps, duration is typically more than 7 days. That is point number one, duration. Point number two, presence of ocular symptoms, swollen eyes, which is not a feature of FMF. And number three, not colchicine, but steroid use is beneficial in the management of traps. Okay, so the type of amyloidosis is same. There is going to be AA, that is secondary amyloidosis only. Okay, here also secondary amyloidosis we are going to get because mechanism is the same. Repeated inflammation can cause burden on the kidney, acute phase proteins leading to the same end complication. So summary is that what are the points here? That the duration is different, ocular symptoms are present, and steroid use is indicated rather than colchicine. So the young boy may come with fever along with rash over the torso, along with ocular symptom. Please suspect traps. So what happens here? Again, please remember, again, very good question. Again, we have to focus on concept. Many questions I'm getting, what is the duration of therapy? Okay, get the concept again. What is the duration of therapy? Please, everybody listen to me. What is the duration of therapy? Who decides that? Remember, in medicine, when a disease is idiopathic, or genetic, it is usually irreversible. I cannot change it. In such cases, the treatment is usually lifelong because I cannot correct the cause. Whenever I know the specific cause, then the treatment will be till the time the cause is reversed. So please stop asking this question, rather understand the concept. In hypertension, example, in a hypertension which is essential, treatment is lifelong. But when hypertension is due to the pheochromocytoma, removal of the tumor can reverse the hypertension. So antihypertensive is given till removal of tumor. So same way, in autoinflammatory disorders, the genetic basis cannot be reversed. So the treatment more or less is lifelong because there is no cure to the disease. The treatment is lifelong. I'm very happy because more questions you ask, more basic concepts we hit, more easy it will be to go through medicine better together, right? So good. Let's keep the questions going. Okay. Which gene? Not important. Okay. The names of the gene are complicated. Not important. What is relevant? Only we will focus upon again. Right. So let's go ahead. So what we have done now? We have understood auto-inflammatory disorders. Okay. Auto-inflammatory disorders. We have got it here. So recall. What are the points we want to look for? So what we studied today? Rheumatology is the study of systemic autoimmune disorders. Please remember, rheumatology is the study of systemic autoimmune disorders. What we completed, but before the rheumatology, we completed the topic auto-inflammatory disorders. Everybody, auto-inflammatory disorders are innate immunity excess conditions, present as periodic fever, and that's what we got, right? We also know what are autoimmune disorders. That question we already answered. So what is left to answer? What are the causes? What are the causes and mechanism involved? We want to study that today. So we want to study what are the mechanisms? Why does a person develop autoimmune disease? That's our concept here. Okay, why does the patient develop autoimmune disease? Why do they develop autoimmune disease? Right? Let us write it down here. Very important table. Let's make a very important table here. That here we have got exogenous factors, endogenous factors. Exogenous factors and endogenous factors. Exogenous factors are outside the body. Exogenous factors are the one outside the body. Endogenous factors are inside the body. Okay. So everybody, again, Anna, for all those of you who are asking steroids lifelong, Anna, steroids are one of the most remarkable discoveries, Anna, invention of our time. Steroids are life saving. Please remember, we are not giving steroid to a healthy patient. We are giving steroid to prevent a deadly complication. Any drug, when it is given, it is always the risk versus benefit that we want to calculate. Again, I am telling another concept, risk versus benefit. Okay, risk versus benefit. Okay, sorry, in anybody has a doubt that in the lecture in any place if I have written colchicine in FHF, okay, please change that. Colchicine was tried, but clinical trials did not show success. So steroids have shown more favorable success. So please change that and let us keep that, right? So exogenous steroid. What are the exogenous factor? Number one, very good. One of you have written correctly. We have got molecular mimicry. So classical example is the rheumatic fever. Classical example is the rheumatic fever. Yes, I will change the background next time. Yeah, in any next slides, we will change the background. So we have got exogenous factors. Number one, most famous is probably molecular mimicry. So why does our immune system start attacking our own body? It starts attacking our own body in rheumatic fever because there is a cross reaction between streptococcal antigen and the self antigen of the body. So immune system believes that our antigen is actually the bacteria. That is why there can be a immune excess, autoimmune phenomena can occur here. So one mechanism is molecular mimicry. Let us look at the second point. So second point is super antigen stimulation. Second point is super antigen stimulation. Classical example in staphylococcal shock syndrome. So what is super antigen? Most of the time average antigen stimulates only 0.1% of peripheral T cell pool. Write it down. I'm waiting for you. So I'm waiting for you. Super antigen. First write down average antigen stimulates less than 0.1% of the peripheral T cells. Average antigen stimulates less than 0.1% of the peripheral T cells. But a super antigen is the Rajnikant of antigens. Super antigen stimulates more than 20% of the peripheral T cells. Super antigen stimulates more than 20% of the peripheral T cell. So you can imagine, after a severe threat, it is very normal that people remain alert for longer. Imagine, if there is a small robbery, people will forget it next day. But if there is a bomb blast, people will not forget it immediately. So if there is a super antigen infection, the immune system remains hyperactive for long. Immune system remains hyperactive for long. Okay. So please remember. So what is this? Average antigen 0.1, 0.001 also. So it's a range. I'm saying up to 0.1% average antigen can stimulate. Super antigen stimulates more than 20%. That can cause autoimmune response. That is one. Number three is the microbial adjunctivity. Third point is the microbial adjunctivity. Please remember, I am giving a common example relevant in our country. When you look at the cases during the monsoon season, when you have malaria, dengue, co-infection, the risk of getting the thrombocytopenia, risk of getting ARDS is found to be much higher. So probable hypothesis is that a microbial adjunctivity. So together they activate the immune system more extensively, leading to a more sustained response, which can actually go on the excess and cause damage to our own body. So the three exogenous factors associated with autoimmunity: molecular mimicry, super antigen stimulation, microbial adjunctivity. Okay, come to the other side. Okay, so come to the other side. Endogenous factors. Endogenous factors altered antigen presentation. Okay, so question that if any topic is taken new, not taken in live lecture, it's not like that. The point is what, yes, very correct, it is the point of time management. See, every faculty is teaching in an integrated manner. So I am sure that part of what I am telling you about the basic concepts may have also been covered in microbiology, part in pathology. As faculties, we discuss with each other. We are not enemies, no? We discuss with each other. So we decide what is most important so that you don't miss out on what is important. Now that we have got a little advantage of time on our side, little advantage, I'm not going to take a massive advantage of this, but let us build it, because this is a one time thing, right? So we are going to complete this. So we will do this one thing at a time, right? So endogenous factors. So we have got here on a microbial adjunctivity. I said that when there are two or more infections simultaneously. Every infection is going to stimulate the immune response differently. They are going to discuss it differently, right? So what happens is that the immune response is much more than having only one infection, and that can cause the overall immune response to be more than normal. That is one of the hypotheses that we have. One of the hypotheses that we have, right? So least important, I will not say. Least important may be for direct MCQ. What I am teaching you extra from live class. Not important for direct MCQ, but important for concept building. That's what we want to achieve again. Okay. Don't have to make notes again and again. This is small. One small sticky note is all it takes, right? So don't be dramatic. Anna, we are all very great dramatics, Bollywood people, but let's take it with pinch of salt little. So endogenous factors we have got. So we have got altered antigen presentation, increased T cell B cell function. So apoptotic defects. After the cell is stimulated, it should go away, but it may not go away. So immune cell lingers for longer. Immune dysregulation. We have heard this mechanism in inflammatory bowel disease. Immune dysregulation. We have heard about it. And cytokine imbalance can be there. Cytokine imbalance can also cause these problems. So leading to excess stimulation of the adaptive immune system. So these are just points to be noted here. Points to be noted, right? So not to be given. Colchicine not in FHF. Only steroids in FHF. That is a recurrent doubt. So I am putting it here. So these are our mechanisms. So let us recall it here again. So what are the recall points? We know definition of rheumatology. We know what is autoimmune disease. And now we know what are the causes and mechanism involved. We know what are the causes and mechanism involved in autoimmune disease, right? So now we are actually ready to start with our topic of autoimmune disease, that is rheumatology. So one by one it's going to be there, right? So rheumatology. Now let us enter the clinical realm. Okay, let us go more into clinical concepts now. So till now what we have done is understood the theoretical aspects of the topic. Let us take a little point of the clinical realm. Let us take example of the go into the clinical realm. So first point, two questions come to our mind. After knowing the basics, yes, after knowing the basics, we want to know how to translate this into clinical practice. So question number one comes that when to suspect autoimmune disease. When do we suspect autoimmune disease? And number two, how to make a presumptive diagnosis. These are the points we want to know, right? So we want to know, right? So what are the points here? So again, let us see the question here. Let us see the question here. What are the causes of PUO? Okay, especially in our country. What are the causes of PUO or pyrexia of unknown origin? Let us see. Okay, so pyrexia of unknown origin we want to see. So in pyrexia of unknown origin, number one in our country remains tuberculosis. Other infection like endocarditis can also be part of the PUO workup, right? So again, few people are asking doubts. Cytokine is in innate immunity. Why autoimmunity? Please focus what I am saying. Excess of cytokine can stimulate the T cell and B cell, which in turn causes adaptive excess. I am mentioning that. Please listen to the full point. Okay. Listen again. I am telling. Listen, then write. Don't copy. Then you will have only doubts. You will not have any knowledge. Only doubts. So it is cytokine imbalance can cause excess stimulation, thereby causing autoimmune response. It's a process. Na? It's a step. That's all. So what we have got here? Occult tuberculosis. Infection remains number one cause of PUO in our country. It can also be autoimmune disease. It can be neoplasm. It can be drug fever or factitious fever. So let us remember here. Okay. So causes of PUO. in our country, first number 1 stands infection. Number 2 stands autoimmune disease, neoplasia or drug or factitious fever. So question number 1 that we are attempting to answer, when to suspect autoimmune disease. What is our question? When to suspect, how to suspect autoimmune disease. Well, the answer is simple. So when patient comes with recurrent unexplained fever, when patient comes with recurrent unexplained fever, right? So we want to know it is autoimmune disease. So unexplained fever, after excluding infection, you think of autoimmune disease. That is number 1. Autoimmune disease, number 2, with multi-organ involvement, that becomes our rheumatology. So what is the question? Question is how to suspect rheumatology disease. So patient is coming with recurrent fever, but all the routine tests for infection are coming negative. So we feel it is autoimmune disease. And along with autoimmunity, there is also systemic involvement, and that is why we think of the point. That is why we think of rheumatology disease. That is when we think of rheumatology disease. We want to know, right? So factitious fever and a fiction. So that is what it is not true. So just to know, second question was how do we reach the presumptive diagnosis? Now all of you are familiar that we know in how to make a presumptive diagnosis of infection. How to make a presumptive diagnosis of infection? We know Koch's postulates. We know Koch's postulates. Koch's postulates, we know that first is to isolate organism from the sick case. So how do we say that this disease is because of infection? When we can isolate organism from the sick case. Number 2, we can grow the organism in the culture, and we can inoculate the same organism into healthy host, and when it becomes sick, you can re-isolate from the sick case. This is what we are taught in Koch's postulates, how to make a presumptive diagnosis that the disease is infective. That is, the disease is infective. So my question in today's class is how to make presumption that it is autoimmune. Please focus here. Instead of the word organism, in infection we have got organism, and in autoimmune disease we have got antibody. So instead of the word organism, I want you to replace it with autoantibody, and you will be able to make a presumptive diagnosis. So when we want to make a presumptive diagnosis, all we need to know is the presence of the autoantibodies we want to look for. So instead of the organism, when we suspect the disease could be autoimmune, what we want to look for? Presence of autoantibodies. So we want to look for presence of antibodies in the blood. Number 2, rather than growing in the culture, we want to look for relevant antibody in the pathological lesion also. Antibody, if it is present only in the blood, that is called as autoimmunity. Only when it causes inflammation in an organ, it is called autoimmune disease. So you also, along with documenting autoantibody in the blood, you have to document the same antibody in the pathologic lesion. You have to look at the antibody in the pathological lesion. And along with that, you have to demonstrate that relevant antibody can cause the disease. So different models, some may be transplacental transmission or adaptive transfer into animals, or you want to look at in vitro impact on cellular function as a supportive evidence. So Koch's postulate told you, you can call a disease is infective if organism is regularly associated with the disease, organism can be grown in culture, and organism can be transferred to other person. Autoimmune disease, we can say disease is autoimmune when you can find autoantibody in the blood. Number 2, you can isolate autoantibody from pathologic lesion, and you can induce the same disease in other models. Then you can make a presumptive diagnosis that it is an autoimmune disease. right? Supportive evidence. Along with this measure, we can also look at animal model, beneficial effect from immunosuppressive drug. All of you will agree, many times in practice, we may not actually culture the exact organism causing the infection. But what we do, we give empirical antibiotic. When the empirical antibiotic causes relief of symptom, we say it is likely it was infection because this antibiotic worked on the infection and led to relief of symptom. But in autoimmune disease, instead of antibiotic, we want to replace it with the word immunosuppressive treatment. So when the patient comes with suspected fever, infection is not there. But what is there in place of organism? Autoantibody is there. And this autoantibody which responds to immunosuppressive treatment, then all the more reason to say that we are dealing with autoimmune disease. And if you have association with other evidence of autoimmunity, please remember, what is the dictum in medicine? Disease is known by the company it keeps. When a patient has predisposition to autoimmunity, he or she is likely to also have other features of autoimmune disease. That's why we say, no, if there is also diabetes, so autoimmune disease, destruction of pancreas is there. Other autoimmune disease can also occur with higher risk in the same patient. So that can be supportive evidence. And most important in our country, there should be no evidence of infection or other obvious cause. So as I told you, again focus on the clinical realm. What is clinical point? When to suspect autoimmune disease and how to make a presumptive diagnosis that we are dealing with a autoimmune disease. That is most important for us to know. So recall, these are the two questions we had. Now everybody answer this for me. Anna? So we want to answer this. When to suspect autoimmune disease or rheumatology? First answer, when to suspect autoimmune disease? In a patient with unexplained recurrent fever with no obvious infection. Unexplained recurrent fever with no obvious infection. And when to suspect rheumatology? When you have multi-organ involvement. So putting it together, in clinical practice, in MCQ, when will you suspect disease is rheumatology? When disease has given autoantibody present. There may be other autoimmune disease, infection is not there, and there is multi-system involvement. Then you must think of rheumatology disease. Next question we had, how to make a presumptive diagnosis. Next question we had put up, how to make a presumptive diagnosis that it is rheumatology. So by excluding the common infection followed by antibody testing will help diagnose autoimmune disease. So this is going to be the thread throughout our rheumatology. So today is the first session. This is just the basics of what is coming next to you. Details of rheumatology we are going to learn with each passing day. But today I hope we have built a certain basis, strong basis to what is rheumatology. All of us now know the basic physiology of the immune system. We know the various pathology, that is disorders of the immune system. Among the pathology, we know immune excess of innate immunity, auto-inflammatory disease. We also know basis of autoimmune disease, the mechanism involved. We know that if it is multi-organ, it is rheumatology. We know how to suspect rheumatology and what to do when we suspect rheumatology disease. First in the country, please remember, in our country, first you have to exclude infection. Only after you exclude infection, think of autoimmune disease. And when you do that, what you want to go for? Antibody testing. We want to proceed for antibody testing to help diagnose the disease. So throughout rheumatology, when we discuss each and every disease, what will be the pattern? Clinical suspicion. Clinical suspicion will be based on epidemiology and clinical feature. Based on clinical presentation, suspect the disease. Then assessment method, go for antibody testing. With the feature antibody is present, you can confirm the disease. And then we learn about the management of that disease. So this is our going to be the point in our disease. So both questions have been answered. How to suspect autoimmune disease, how to make a presumptive diagnosis, right? Continue further. So coming to rheumatology. So today we are going to end with classification. We are going to end with classification so that we can divide what is coming next. So rheumatology, we want to classify into the three main groups. Okay, everybody, we'll make a chart here. We'll make a table here. How do we make this change? Right? So rheumatology classification based on two important factors. We will start at the top. One, characteristic feature if it is present. So if the characteristic feature is present, and number two, the screening antibody present. So rheumatology, what it is, all of us are clear now. How to suspect, what to do, we are also familiar. Now let us classify the disease for today. Let us classify the disease for today. That's what we want to learn, right? So we have got here rheumatology diseases are classified into three groups based on the characteristic feature if present, not always present, if present. Characteristic feature is not most common. Don't confuse between the two, right? And then there is the screening antibody present. We want to see. Okay. So please remember, you can see again, all the students who are worried about the slide I'm telling, you can always go through the video and you can catch up. And whatever is important, I'm giving it time. Okay. So please don't get stressed again. Major criteria slide, you can see it's going to come in the video. You please continue forward with me, right? It is just to fill you with the basics. Okay. It is not that those points are exactly going to come in MCQ. I told you, those are more for concept building. So take it with the points and come forward. So first point, group what we have got to discuss is the lupus disease. So we have got lupus disease. So why lupus disease? Most famous we know. When we think of rheumatology, we think of SLE. How do we keep it? How do we keep it? So lupus group, when the characteristic feature, why it was called lupus? Because the patient used to have wolf bite like skin rash. The characteristic feature, lupus means wolf bite like skin rash. That is why the name was given lupus. And the most common antibody seen in lupus disorder is ANA. Most common, that is screening antibody seen in lupus group of disorder is the ANA. So first we have got is the lupus group of disease. Lupus group of disease, right? So we have got characteristic feature screening antibody. Number two, we have got the arthritis group. Number two, we have got arthritis group. Arthritis group, we have got joint deformity. When joint deformity is there in the patient, you think of arthritis syndromes. And the most common antibody found in arthritis group of disease is RA factor. That is rheumatoid factor. That is rheumatoid factor. Right? So we are just coming further. Is that vasculitis group. Third group is the vasculitis group. Vasculitis group, when the patient has got purpuric skin rash. Purpuric skin rash, if it is present, then it is specific of the disease, not common. It is specific of the disease. And the most common antibody present is the ANCA, anti-neutrophilic cytoplasmic antibody. Okay. So please focus screening antibody. Anti-CCP is the specific antibody for arthritis, not the screening antibody. Okay. So I am making the classification here. So we know what are the points. We are writing classification of rheumatology disease. So based on two features. One is the characteristic feature and number 2 is the screening antibody. We have broadly classified rheumatology into 3 groups. So we have to discuss them one by one. We have got lupus group, arthritis group, vasculitis group. Lupus means wolf. Anna, you have not seen Harry Potter? Professor Lupin. Anna, who has not seen Harry Potter? Pranab Bhaumik. Anna, very interesting. Lupus, meaning of lupus. You must watch Harry Potter. Anna, most Hollywood movies are better researched than our medical lectures in India. Anna, so we must watch them once in a while or commonly also. Lupus is wolf. Wolf bite type of rash. Okay. So this is what we have. Based on that, we divide it into 3 important. Got it? So noted, no yellow. We'll change the colors. By tomorrow's lecture, we'll change the colors. And whatever are those technical difficulties, we'll sort it out. Right? Chalo. Next point. So within the disease, within the 3 main group, continue this table. Continue this table. Yes, continue this table. So continue the table within the lupus disease based on the characteristic feature and antibody present. Based on the characteristic feature and antibody present, we reach the final diagnosis. So how it is? It is a table, continuous table. First we made the table based on the feature, broad divide into the 3 group. Within the group, within the 3 main group, again I am repeating, this is continuation of the first page. Within the 3 main group, in lupus group, based on the characteristic feature within the group and the specific antibody, we call them as SLE, scleroderma, that is also called systemic sclerosis now, and Sjogren's syndrome. 3 topics we want to study. 3 topics we want to study under lupus group of disease. 3 topics under lupus group of disease. So one day class is going to be lupus group of disease, where we will discuss all 3 topics. Number 2 group, arthritis group. Arthritis group is further subclassified based on the pattern of joint involvement. Further subclassified based on the pattern of joint involvement into rheumatoid arthritis, spondyloarthropathy, short form SPA. Remember, rheumatoid arthritis, spondyloarthropathies, and crystal-induced arthropathies. Arthritis group, we are going to subclassify into RA, spondyloarthropathy, crystal-induced arthropathy. Yes, few minutes more only. Just we are completing classification today. Tomorrow we will be doing lupus disease. After that we will do arthritis disease. So I am classifying, dividing the rheumatology into sessions. Then we will go for vasculitis group of disease. We will study vasculitis group of disease. Within the vasculitis group, based on the size of the vessel predominantly affected, we will classify them into large vessel, medium vessel, and small vessel vasculitis. Okay, so how it is? It is a sequential table. The first table we classified broad all rheumatology disease into 3 categories. Then we are going to have sub classification within the group. Within the group, what we want to discuss, I have already put up. So day 1 is today. We understood basics of rheumatology. Tomorrow we will do lupus disease in detail. Day after or later, whenever next class, we will see arthritis group, then vasculitis group, and last we are going to see the other miscellaneous groups we want to discuss. One of them is the myositis syndrome. So in the 20th edition Harrison, myositis has come from neurology into rheumatology. So we will deal with that. So we will be discussing myositis syndrome. Under myositis syndrome, we will discuss polymyositis, dermatomyositis, and inclusion body myositis. So we are going to discuss here, we are going to have polymyositis, dermatomyositis, inclusion body myositis. And under overlap syndrome, we are going to discuss two topics, MCTD and lupus, mixed connective tissue disorder and lupus. So again, sub-classification. Other groups along with one day lupus, second day arthritis, third day vasculitis, fourth day we will discuss myositis syndrome. We will conclude with overlap syndrome. Okay, we will complete overlap syndrome. So that's how we will take it one by one. Okay, that is the classification. So what we are done, recall the integrated approach. So to conclude the class today, what we have got, we have done review of physiology. Yes, everybody, we have done, I hope everybody knows what is normal immune system, number one. Number two, what we have done, classify the disorders. We have done classification of the disorders. So this is where we have reached. This is where we have reached. Okay. From tomorrow, we will continue. We are going to start tomorrow's session with antibody testing, and then we will take it forward to the individual disease. Right. So that is what we have for today. We'll try to make whatever relevant changes to help you understand and integrate. Okay. So take it one at a time. It will work out. Once you go through this together, you'll be able to do it much better. Chalo. So good night, everybody. So tomorrow 7:30 we'll start with antibody testing, and then we will go on to individual disorders. Yes, I'll put the last slide here. Okay, for you to see. Right. So thank you. Good night. Others can go. Anybody has doubts, any points which are left, we will try to take it from there. Right. So I will play the slides for you. Okay. I can play the slides for you. Whoever has missed any specific slide, you can ask me. We will go through that and continue tomorrow. Others can run away. Right, major criteria slide I will keep and end the session. Okay, on major criteria which everybody is wanting to know, I'll just keep the slide on that. Okay, and we will take it a break. So this is our major criteria for autoimmune diagnosis. Okay, chalo, good night.